You're right. Let's land again into, let's say, a more normal life. This is my disclosure. I don't think there is nothing to deal with my presentation now. It is the management of an unstable reverse shoulder arthroplasty. So, prosthesis instability is something that may happen, and you see that overall it is about the same between anatomical implants and reverse. It is 4.6, 4.7, 5%, let's say. And the complication in reverse total shoulder arthroplasty is ranging from 2.4 to 31, and instability in reverse is ranging the same amount, more or less. Which are the risk factors about the epidemiology, about the risk factor of instability? It is revision, soft tissue deficiency, of course, subscapularis or weak deltoid tension, excessive medialization, or bone loss from the glenoid or humeral side. You may have an early dislocation that is intended like after 3 months from surgery, or the late one that is after this period. And again, this is the epidemiology that I already described. Let's go back very briefly to the functional biomechanics in the reverse. The soft tissue envelope that is around the implant is tensioned by the distalization of the humerus and the medialization of the center of rotation. And the combination humeral and or glenosphere lateralization and distalization may lead to a balanced result with a good stability of the system. So starting from this, again, we need to consider about the medialization of the central rotation, because constrained prosthesis with a large ball may present some advantages, reducing the torque secondary to the neck, to no neck on the glenosphere, increased recruitment of deltoid fibers from the medialization, and deltoid tension is taken from lowering the humerus. When you lateralize the center of rotation system, the glenospheres are usually smaller, the center of rotation is medialized, but not as much as a medialized center of rotation, and deltoid tension is created from the lateralization of the center instead of lengthening the humerus. So the biomechanical principle is changing. Primary versus revision. Rate of instability is similar in patient with primary, 5%, and revision, 8% revision arthroplasty. And again, previous surgery, surgical approach, soft tissue deficiency, glenoid humeral bone loss, and implant malpositioning are listed in the possible causes of an unstable reverse shoulder arthroplasty reported in the literature. Fracture sequelae also is a group that has a very high rate of instability, reaching up to 28%, so be aware of this. And then the risk of factors for instability in medialized and lateralized design. You see here the odd ratio, where there are in favor of the repair or not repair of the subscap. Some cases may benefit from this, some others may not, and it was already described earlier during the discussion, because the repair of the subscap may interfere with the full range of motion of the new design shoulder. Risk factors again, greater superior base plate inclination. I hope this is not happening anymore. We did it in the past. And less inferior correction of the beta angle. So we really need to have a proper position of the base plate. There are attempts to classify the instability causes. This is Mark Frankel who reported this. If you have a reverse shoulder arthroplasty dislocation, is this a mechanical failure? If yes, you have a loss of containment. If it is not, you may have an interposition of soft tissue. If not, you have laxity of the components. If not, you have an eccentric polyethylene wear going to loss of containment. If you go for concentric wear, you have a loss of compression. So otherwise, you may go to some impingement, some mechanical hitting that is dislocating it. So loss of containment and loss of compression and loss of containment may lead to unstable reverse shoulder arthroplasty. And of course, we need compression for stability, and of course, we need the placement, the proper positioning of the components of the prosthesis. How we can reduce it? Closed reduction is described in the literature, or open if it is not successful. Instability reduction of the reverse shoulder arthroplasty is described. The technique it is a paper who described it. The technique involves position of the arm in 45 degrees abduction and neutral rotation, longitudinal traction, and posterior and inferior directed force are applied to the proximal humerus and will sometimes reduce the prosthesis. I'm not that good, so I was not able to succeed all the times when I tried to do so. Using a sheet under the axilla for counter traction can be useful, an useful aid. And AP, anterior, posterior, and axillary radiographs, of course, to control if you really were successful. Close reduction in early dislocation is unlikely to avoid recurrence because, of course, there is some other problems behind it. If you have an early dislocation, there is something wrong with too much medialization or poor positioning of the implant due to the fact that the dislocation is caused by this malpositioning. Close reduction followed by up to 6 weeks of sling immobilization and avoidance of extension, abduction, and internal rotation, hoping that the soft tissue will scar all around and then stabilize the implant. Close reduction should be done as an initial dislocation episode after dislocation and can be successfully managed, but of course the outcome after revision surgery are not different from those after close treatment. Again, here it is the algorithm of an open reduction. If you are not successful with your close reduction, you should check and decide if there is an infection or not. You need to check if you have a numeral shortening. If it is lower than 15 millimeters, you simply may exchange some part of your implant in order to increase the tension of the soft tissues. If it is more than 15 millimeters, the humeral component revision is important so that you have a better tensioning achieved also by the length of the humerus. Humeral medialization, again, 15 millimeters seems to be the magic number. If you have less than that, larger glenosphere and increased lateral offset should prevent the recurrence of the instability. If it is more than 15, glenoid base plate revision with an augment or lateralizing structural bone graft may help. If you have an acromial stress fracture, then let's say skillful neglect is what mostly recommended, and JP described some cases about it, just immobilizing this for 4 to 6 weeks and wait. So the strategy is multifactorial, and again, look at the length of your implant and the position of the implant first of all. Rule out medialization and lateralization, and of course infection. What about the version of the humeral component? So far I spoke much more about the glenoid side. There are some critical factors for intrinsic stability, and the version of the glenoid component is less important, but still may influence this. So according to the version that you achieve, you may improve the stability of the system according to the position. You see that here in the graph, you have the stability ratio, and when you have 20 degrees of humeral anteversion, you may decrease instability or increase instability according to the interface between the glenoid implant and the humeral side. So an interaction of the two sides of the moon are important to improve your stability and range of motion. If you have a glenoid bone defect, metallic augmented base plate may help eventually in order to correct the anatomy that is wrong or what you are missing, and you may have this custom-made glenoid base plate. Some examples in my life: lady, 61 years old, a fracture of the proximal humerus, treated with plating. She got an infection, reverse, and of course missing a lot of bone. You see that the implant has no bone in the proximal part, dislocated, and in this case just increasing the lateralization. Look at the acromial position in the first implant and in the second one. This is a typical Grammont design. 150 is the angle that is the cut here, so lateralizing on the humeral side was enough to provide good stability. This is not always true. This is a boy that I took after 7 procedures, and with this instability, in this case, I decided to go for a humeral, glenoid and humeral lateralization. So I used a larger glenosphere plus a lateralizing, sorry for all this picture. Okay, lateralizing liner that is increasing also the tension and the wrapping of the deltoid on the humeral side. So the both sides just to help it. So prosthesis instability is different according to the implant. Can be different causes: malposition, soft tissue failure, bony defect. You should have a tailored strategy, and use the possibility of exchanging the parts of your system may eventually help you. Higher risk of complication when you have some the sequelae of fracture, and it is sometimes challenging and often with more limited results, of course, if compared to a primary implant. I want to thank you. This is my last presentation, and I part of the chorus saying thank you, Manos and Manos, because this was a great time here in Athens with all the friends here. Thank you very much.